Everyone, and welcome to this explainer. Look, if you're gearing up for your medical entrance exams, I know you are already feeling that intense pressure of memorizing literally countless pathogens, pathways, and pharmacology rules. Your time is incredibly valuable, right? So we are going to skip the fluff completely today. I'm going to walk you through a highly focused, super high-yield review of Haemophilus and Moraxella infections. We'll use clinical syndromes and mnemonics to build distinct mental boxes for these bugs so you can lock in those critical points and instantly recognize the classic buzzwords the second they pop up on test day. All right, let's dive into this.
Here is our roadmap for today. We'll start by meeting the pathogens, tackle Hib, the encapsulated threat, and confront NTHI, the mucosal menace. Then we'll cover H. ducreyi, painful ulcers, Moraxella, the hockey puck, and finally bring it all together in a master comparison guide.
To get us right into the exam mindset, think about this classic board-style differentiator. You have a patient presenting with a genital ulcer. Is it painful or is it painless? Is the lesion indurated and firm, or is there a fluctuant bubo? Examiners absolutely love to test your ability to instantly separate one bug from another based on just a couple of key clinical descriptors like these. Well, over the next few minutes, we're going to crack the code on these exact types of questions.
Section 1. Meet the pathogens. Let's look at the basic microbiology.
First off, notice the absolute nutritional neediness of Haemophilus influenza. It's a gram-negative pleomorphic coccobacillus, and it simply refuses to grow on standard blood agar. No way! It requires two very specific things to survive: the X factor, which is hemin, and the V factor, which is NAD. To actually get these factors, you have to heat the blood to 80 degrees Celsius. This lyses the red blood cells, releases the X and V factors, and creates what we call chocolate agar. So here's the takeaway. If a question stem specifically mentions growth exclusively on chocolate agar, Haemophilus should immediately jump to the absolute front of your mind.
Section 2. Hib, the encapsulated threat. Time to talk about capsule virulence. Haemophilus influenza type B, or Hib, is really the heavyweight champion of these pathogens, and that is entirely due to its PRP polysaccharide capsule. This capsule is its major virulence factor. So what does Hib actually cause? Most seriously, it causes meningitis, primarily in kids under 2 years old. This carries a 5% mortality rate and a 6% risk of permanent sensorineural hearing loss. It also causes a very distinct cellulitis that presents with a bluish-red discoloration on the head or neck, along with pneumonia that frequently involves the pleura. Now, the absolutely crucial point here is the treatment. For Hib meningitis, you've got to use ceftriaxone, but examiners love to test the addition of dexamethasone. Why? Because giving dexamethasone actually reduces those devastating neurological sequelae.
Another terrifying clinical syndrome traditionally caused by Hib is epiglottitis. I want to quickly narrate this rapid, step-by-step escalation because this exact clinical picture is a massive exam favorite. It usually starts innocently enough with just a sore throat and a fever. But then it rapidly, and I mean rapidly, progresses to severe dysphagia and drooling simply because it hurts way too much for the patient to swallow. Next comes the stridor and that classic muffled hot potato voice. Step 4 is the most important thing to realize. This is an absolute airway emergency. Now, in the post-vaccine era, we actually see this a bit more in adults, but that rapid progression remains exactly the same.
And this brings us to the radiographic buzzword you absolutely must know for epiglottitis: the thumb sign. If a question stem describes a patient who is drooling with a hot potato voice, and they tell you the lateral neck x-ray shows a swollen epiglottis that literally looks like a thumb sitting right there in the airway, well, it's epiglottitis. Visually burn this phrase into your brain, guys. It is a guaranteed point on test day.
Section 3. NTH, the mucosal menace. Let's look at the unencapsulated strains.
Non-typable Haemophilus influenzae, or NTHI, lacks that dangerous polysaccharide capsule. What does that mean for us? It means it doesn't typically cause those invasive, systemic diseases like meningitis. Instead, you should frame these in your mind as chronic, everyday mucosal annoyances. Importantly, NTHI is the #1 bacterial cause of acute exacerbations of COPD. In these specific cases, you aren't typically going to see high fevers or new infiltrates on a chest x-ray, just worsening respiratory symptoms. It is also the second most common cause of otitis media in kids, right behind strep pneumoniae. Why is it so stubborn in the ear? Because NTHI forms these really persistent biofilms in the middle ear, which leads to recurrent infections.
Section 4. H. ducreyi, painful ulcers. We're pivoting to a sexually transmitted bug.
First, a really quick microbiology note on H. ducreyi. Unlike H. influenzae, which needs both the X and V factors, H. ducreyi is a little different. It requires only the X factor, hemin, to grow. But honestly, the massive exam buzzword you need to remember right here is the school of fish appearance. When you look at H. ducreyi on a gram stain of a lesion, the bacteria actually line up in parallel chains that examiners always describe as a school of fish.
Okay, now for the clinical presentation. This is arguably one of the most classic traps in all of medical board exams, so pay attention. H. ducreyi causes chancroid. Chancroid is a painful genital ulcer. It is not indurated, meaning it's soft, and it's accompanied by tender inguinal lymphadenopathy. This is often a fluctuant bubo that might even spontaneously rupture. Now, contrast this directly with the primary chancre of syphilis. That one is painless and heavily indurated, or firm. Do not mix these up. The classic mnemonic is, ducreyi makes you do cry because it's painful. Treatment for this painful chancroid is typically a single dose of azithromycin or ceftriaxone.
Section 5. Moraxella, the hockey puck. Introducing our gram-negative Diplococcus.
If you see the phrase hockey puck sign, you are dealing with Moraxella. In the lab, M. catarrhalis colonies will literally slide completely intact right across the agar surface when you push them with a loop, just like a hockey puck on ice. This perfectly separates Moraxella from its Neisseria cousins, whose colonies just sort of break apart the second you touch them. It's a highly testable, great visual mnemonic.
Clinically speaking, Moraxella causes otitis media in kids and is the second most common bacterial cause of COPD exacerbations. But why does this specific pathogen matter so much for your treatment plan? It all comes down to this staggering statistic right here. Greater than 90% of Moraxella strains produce beta-lactamase. This means it is highly resistant to plain amoxicillin. You absolutely must use amoxicillin combined with clavulanic acid or an extended-spectrum cephalosporin if you want to defeat it.
Section 6. The Master Comparison Guide. Let's synthesize all of this.
Go ahead and take a mental screenshot of this master comparison guide. Seriously, it summarizes exactly how all these pathogens relate and differ for really rapid exam recall. Look at the growth row. Hib and NTHI need both X and V. Ducreyi needs X only. Moraxella just grows on standard blood agar. Now look at the capsule row. Only Hib has that PRP capsule, which makes it the invasive outlier, causing meningitis and epiglottitis. NTHI lacks a capsule, but remember, it's your absolute #1 for COPD exacerbations. H. ducreyi causes the painful chancroid. And finally, for treatment, notice how Hib gets ceftriaxone. But for our mucosal menaces NTHI and Moraxella, you're always reaching for amoxiclav because of that pesky beta-lactamase production.
I want to end things today on a final, provocative question. One that goes beyond just memorization and right into a life-or-death clinical application. If a patient presents with drooling, stridor, and a lateral neck x-ray showing the thumb sign, what is your first priority? The answer? Airway security, period. And the golden rule here? Do not, under any circumstances, attempt to examine the throat with a tongue depressor, because doing so can precipitate a complete, fatal airway obstruction. Remember that crucial clinical pearl, visualize these concepts, and you are going to completely dominate these questions on exam day. Thanks so much for joining me in this explainer, and keep up the great studying.